Welcome to the Asia-Pacific HIV Clinical Forum 2020. Our theme this year is optimizing treatment. You may be aware that this is the first virtual meeting of this Asia-Pacific Clinical Forum. This meeting will be a two-day meeting. So we start. Let me introduce myself. My name is Kiat Ruxrungtham. I'm a professor of medicine at the Faculty of Medicine, Chulalongkorn University. And I also a senior investigator at the IPNET Thai Red Cross Research Center and the director of the COVID-19 Vaccine Development Program of Chula Vaccine Research Center. It's my great honor and pleasure to also introduce our program co-chairs. So we have Professor Shapiro, Jonathan Shapiro, and Professor Boucher, and myself is a local chair. Our objective of having this HIV clinical forum for this region is to update on the clinical utility of integrase inhibitor in HIV treatment and update other latest research data to support our clinical practice, including the implementation of PrEP and have an understanding of prevention strategy in this region. So our goal is really to improve our clinical care of people living with HIV. So here are the whole picture of the programs. This is a 2 days programs. The first day we have the 2 sessions, and the second day also have another 2 sessions, a total of 4 sessions in the programs. Starting for today, we will start session 1 after this introduction and welcoming address. So please submit your question during the session so we can, forward to our speaker and address it for you. Here are our distinguished international faculty members. I think most of the faces are well familiar, both locally and well known internationally. On behalf of the co-chairs and the organizing committee, I'd like to thank the support from VIP Healthcare that are making this wonderful program available for all of us. Now, it's my great honor to introduce our first session chair. Actually, Professor Praphan need no further introduction because, all of us have known and learned from him about his contribution both in the implementing research on HIV treatment and care and also the prevention. He actually also my ex-mentor, my mentor and my boss. So I'd like to welcome Professor Praphan to chair this, the first session of the forum. Thank you very much, Professor Praphan.
Okay, thank you, Professor Kiat, in introducing me and also inviting me to chair this session here. Welcome to the first session of the Asia-Pacific HIV Clinical Forum India 2020. This session is entitled Clinical Management of HIV Treatment in Asia. We have 3 speakers in this first session. I will just introduce the first speaker. Professor Sasisopin Kiertiburanakul. Professor Sasisopin graduated from the Faculty of Medicine, Ramathibodi Hospital, Mahidol University here in Bangkok. She did her residency training in internal medicine and clinical infectious disease fellowship training also at Ramathibodi Hospital. She also obtained her master's degree in epidemiology from Johns Hopkins University. Currently, Professor Sasisopin is the chief of the Division of Infectious Diseases in the Department of Medicine, Ramathibodi Hospital. She also serves as the Assistant Dean for Corporate Communication. At this moment, Professor Sasisopin is the Secretary of the Infectious Disease Association of Thailand and also the Secretary of the Thai AIDS Society under Professor Kiat. Professor Sasisopin is the principal investigator and co-investigators of many international multi-center studies, such as the STAR study. Professor Sasisopin is going to give her opening lecture on HIV drug resistance in Asia. This itself will open up our understanding why we need a drug or drug class which has a higher barrier for drug resistance. Professor Sasisopin, please.
First, I would like to thank the organizer for inviting me to give an opening lecture to the Asia-Pacific HIV Clinical Forum 2020 meeting. This is my disclosure. The outline of my talk today are definitions of HIV drug resistance, the guidance of HIV drug resistance testing, transmitted and pre-treatment HIV drug resistance, and the last one is HIV drug resistance after treatment failure. Why do we need two concerns of HIV drug resistance? HIV drug resistance can compromise the effectiveness of limited options for the treatment to reach the last 90 target. So you can see that the last graph in 2019, only 55 of people living HIV in Asia and the Pacific have undetectable level of the virus. What is HIV drug resistance? HIV drug resistance is the ability of virus to mutate and reproduce itself in the presence of antiretroviral drugs. It caused by one or more than one change or mutations in the genetic structure of HIV that affect the ability of the specific drugs or combinations of drugs to block the replication of the virus. So the consequence of HIV drug resistance include treatment failure, spread of resistance HIV, compromised treatment effectiveness, lower chance to reach the last 90 target, and the last one, increased HIV incidence, mortality, and morbidity. WHO or World Health Organization classify HIV drug resistance into three main categories. The first one is acquired HIV drug resistance or ADR. ADR developed because of virus replication in the presence of ARV drugs. The second one, transmitted HIV drug resistance or TDR. TDR is detected among ARV drug naive people with no history of ARV drug exposure. TDR occurs when previously uninfected individuals are infected with the virus that has drug-resistant mutations. The last one, pre-treatment HIV drug resistance or PDR. PDR refers to resistance among ARV drug naive people initiating ART, or people with previous ARV drug exposure initiating or reinitiating first-line ART. This slide shows the guideline on drug resistance testing. You can see that the HHS and European AIDS Clinical Society recommended among ART naive patients to do HIV drug resistance testing at entry to care. However, you can see that among Thai guidelines, we do recommend drug resistance testing for naive patients just only for one who on PrEP or one who having a partner suspected of drug resistance. In contrast to WHO guidelines, do not recommend drug resistance testing in any setting because of the cost and infrastructure. But all DHS guidelines, European guidelines, and Thai guidelines all recommend to do drug resistance when the patient has biological failure or treatment failure. So let's start with the data of TDR or transmitted drug resistance. This slide shows the result from Treat Asia network or from Treat Asia study to evaluate resistance or TASER study. Multi-center prospective study was conducted in ART-naive patients between 2007 and 2010. 458 patients with recent HIV infections and 1,340 patients with chronic infection were included in the study. There were 11 sites from 5 countries, which is Thailand, Hong Kong, Philippines, Indonesia, and Malaysia. This is a result of the study from Treat Asia. The overall prevalence of TDR is approximately 4.6. Recently infected patients has a higher prevalence of TDR. You can see this is about 6.1 versus 4%. And also the patient with recently infections of HIV has a higher frequency of resistant associated mutation to protease inhibitor, which is 3.9 versus 1%. In multivariate logistic regression analysis in patients with chronic infection, we found that patients with heterosexual contact as a risk factor of HIV infection was less likely to be associated with TDR compared to other risk categories. This slide sought to understand the molecular epidemiology of TDR and identify the mutations responsible for TDR. The authors review all GenBank submissions of HIV-1 reverse transcriptase sequence with or without protease between 2000 and 2013. The table represents the 86 studies with more than 11,000 individuals in Asia. The overall TDR you can see here is about approximately 3% in South or Southeast Asia. And the prevalence of TDR is about 5.6% from upper income Asia country. This is an example of the most common country that include in the study. For South or Southeast Asia is China, Vietnam, and India. For upper income countries is Korea, Japan, and Taiwan. And the result of this study show that the odds of adenosine associated TDR increase yearly in upper income countries in Asia. Odds ratio is about 1.3. The next two slides show the recent study regarding TDR in my institute, Ramathibodi Hospital in Bangkok. The first study was conducted between 2011 to 2014 with a sample size of 265. Overall prevalence of TDR is approximately 8%. The most common resistant associated mutations was K103N is about 6%, and the second one is 184VRI is 4.5%. We also found that having M184VRI was associated with detectable HIV RNA at 6 months after ART initiation. The second study was conducted between 2016 and 2017 with a sample size of 153. Interestingly, we found that the overall prevalence of TDR increased almost 14%. The prevalence of TDR to NRTI was about 5.9, and the prevalence of TDR to NRTI was 10.5. So the cutoff of 10% increased the NNRTI PDR prevalence above which WHO recommend moving away from NNRTI-based ART in first line. Next, I would like to present the data of PDR or pre-treatment HIV drug resistance. This is a systematic review and meta-regression analysis. Include about 89 studies and more than 16,000 genotypes. The sampling year was ranged from 2006 to 2010. The results show that yearly increase in the odds of PDR were 11%. You can see from this figure, the first figure here, that there is a substantial increase in pre-treatment of NNRTI resistance per year by Asia. By contrast, you can see the second figure here that there is a little change in the NRTI resistance, with the model predict prevalence in 2016 is lower than 5%. And NRTI and NRTI resistance were more common among individuals with previous antiretroviral drug exposure compared to ARV naive, with significant difference. In addition, there was an association between MSM and overall HIV drug resistance. This is a result from the previous study. They include approximately 1/3 genotype from Asia. The most common NNRTI resistant mutation was 103, and the most common NRTI mutation was 184V. The prevalence of drug resistance to PI was very low among PI, it's less than 1%. So let's move to the HIV drug resistance report by WHO or World Health Organization. On the left-hand side figure, you show the NNRTI PDR point prevalence between 2014 to 2018. The dot line here is the 10% prevalence. For NNRTI PDR prevalence exceeds 10% in 12 countries of 18 countries, including Nepal, but Myanmar and Vietnam is less than 10%. The prevalence of NNRTI PDR was nearly twice as high among women than men initiating ART. So the latter figure show among people reporting previous ARV drug exposure. You can see that the prevalence of NNRTI PDR exceeds 10% in all 12 countries, including Myanmar and Vietnam. This figure shows the prevalence of PDR to drugs used in first-line regimens as expected. The prevalence of PDR is driven mainly by PDR to efavirenz and nevirapine across all countries. The prevalence of NRTI PDR was low, less than 5%. You can see the blue graph and the purple graph represent the NRTI resistant mutation prevalence. So what is the WHO recommended response to PDR to NNRTI? So start with the question, are nationally represent PDR data available in your country? So if no, PDR survey should be implemented. If yes, what is the number? You can see the number 10% here. So if the high level of more than 10% observed PDR to NNRTI, highlight the need to fast track the transition to non-efavirenz and non-nevirapine first-line regimen. So if non-efavirenz or non-nevirapine first-line regimen is not feasible, pre-treatment HIV drug resistance should be considered. Let's move to some study regarding drug resistance after treatment failure. This study aims to do a global assessment of drug resistance after biological failure of WHO recommended first-line regimen or Integrase cohort. This is a multi-center retrospective cohort study include patients with biological failure with first-line regimen containing TDF plus 3TC or FTC plus efavirenz or nevirapine. There were around almost 2,000 patients from 36 countries enrolled between 1998 to 2015. Of these, there were about 556 patients from Asia, from 4 countries in Asia. So the result determine drug resistance in high proportion of patients after virological failure on tenofovir containing first-line regimen across all low-income and middle-income countries. In Asia, you can see here on the left-hand side, the prevalence of NNRTI resistance was 71%, and the prevalence of M184V or I is 49%, and the prevalence of tenofovir resistant plus others is about 39%. So the risk factor of resistance to tenofovir were pre-treatment CD4 cell count and co-administrator of other ARV. So this slide shows the prevalence of acquired HIV drug resistance reported by WHO. Overall, the prevalence of any HIV drug resistance among all individuals receiving treatment range from 3% in Vietnam to 29% in Honduras. This graph shows just only the data from Vietnam. In Vietnam, you can see the graph, the green bar here, 50% and 80% here of the patient had resistance to efavirenz or nevirapine plus NRTI at 12 months and 24 months after ART. And the green bar here represents 25% and 35% resistance to tenofovir at 12 months and 24 months respectively. This is the last slide show the study investigation pattern on and factor associated with multi-NRTI resistant associated mutation at first line failure in patients from Pre-Asia study to evaluate resistance and monitoring study or TASER-M. A total of 105 patients from 10 sites in 5 countries here, Thailand, Hong Kong, Indonesia, Malaysia, and Philippines. So there were a total of 92 patients harboring one or more than one resistant associated mutations and 37 patients with multi-NRTI drug resistant associated mutations. And the most common NRTI associated mutation was 184V, which is 75%. And the most common of NNRTI resistant associated mutation was K103N and Y181C, approximately 30%. And the factor associated with multi-NRTI drug resistant associated mutation were CD4 less than 200 cells at genotype and ART duration more than 2 years. The virological suppression was achieved about 85% at 12 months after switch to second line ART. So my conclusion about HIV drug resistance in Asia. So pre-treatment drug resistance in some countries exists 10%, especially in NRTI resistance. So we need to characterize the shift of sexual transmission within MSM populations and use of PrEP. If HIV drug resistance testing is not feasible individual level, so countries are encouraged to conduct national level study to determine the level of PDR and define further actions. HIV drug resistance after treatment failure is also a problem. So we need action to prevent HIV drug resistance should be urgently implemented, such as payload testing coverage, retention in ART, minimize loss to follow-up, ARV dispensing practice, timely management to individuals with HIV drug resistance, and transition from NNRTI to more robust drug class such as Integrase inhibitor. So thank you for your attention.
Thank you, Professor Sasisopin, for your nice overview of HIV drug resistance in Asia. We will keep all the questions and discussions at the end after all the 3 speakers have completed their presentations. Meanwhile, you can send in the questions in advance via the link of the conference. It's my pleasure to introduce our next speaker, Professor Chien-Ching from Taiwan. Professor Hung received his medical degree from the National Taiwan University College of Medicine, where he also had his residency training in internal medicine and infectious diseases trainings. Professor Hung later obtained a master's degree of international health at the Swiss Tropical and Public Health Institute in Basel, Switzerland, and then a PhD degree of Graduate Institute of Medical Sciences, University of Antwerp, Belgium. Currently, Professor Hung is a clinical professor of medicine and professor of tropical medicine and parasitology at the National Taiwan University College of Medicine in Taipei. Professor Hung is currently the president of the Taiwan AIDS Society. With this position, Professor Hung is leading the Taiwan HIV study group. Professor Hung will deliver a state-of-the-art lecture in clinical considerations in using integrase inhibitor and update. Please welcome Professor Hung.
Thank you for the kind introduction. These are my disclosures. Today, I'm going to talk about the efficacy and safety and tolerability data of INSTI-based regimens. And I will give a little bit overview of the transmitted drug resistance of HIV-1 to integrase inhibitors here in this Asia-Pacific region. I will talk about the drug-drug interaction between INSTIs and the other agents, particularly those medicines for treatment of tuberculosis. I will also touch on the iris when INSTI were given. And I will talk about the INSTI use in pregnancy and the weight gain with INSTI. INSTI plus 2 NRTIs are recommended as the first-line antiviral therapy in most international HIV treatment guidelines, including WHO. Here you can see the PHS guideline, IAS USA, and EACS, and WHO guidelines all recommend integrase inhibitor as the first-line treatment regimen. But for ARV-naive individuals who had viral load less than 500,000 copies and had no HBV infection, DTG plus 3TC is also recommended. All those 4 orally available INSTIs in combination with 2 nucleoside reverse transcriptase inhibitors are also recommended ART regimen in several Asia-Pacific countries. In this table, you can see the integrase inhibitors based regimen are recommended in Taiwan, Japan, Korea, China, and Singapore. The recommendation of integrase inhibitor as the first-line regimens are based on several pivotal clinical trials that demonstrate superiority or non-inferiority to their comparators. For example, in this slide, you can see the in single study, the DTG plus ABC and 3TC was found to be superior to efavirenz plus emtricitabine and TDF. And in the study 1489, BF-TAF was found to be non-inferior to DTG ABC plus 3TC. In the Gemini study, you can see the DTG plus 3TC was found to be non-inferior to DTG plus emtricitabine plus TDF at week 48. And many of these studies have extended observation to 96 weeks or even 144 weeks. And the non-inferiority in terms of viral suppression remains. And for individuals who had achieved viral suppression, switch to integrase inhibitor-based regimens can maintain excellent viral suppression. For example, in the study 1844, switch from DTG, ABC, and 3TC to BF-TAF can achieve non-inferiority to the continuation arm with DTG, ABC, and 3TC. In the Tango study, DTG and 3TC, when switched from TF-based regimen, can achieve non-inferiority in terms of viral rebound when compared with continuation of TF-based regimen. And the SOAR study, DTG plus ripivirine can achieve non-inferiority in terms of viral suppression when compared with the baseline regimens. INSTI-based regimens, mostly tenofovir-based NRTI in combination, are safe for ARV-naive participants with low rates of drug-related SAE and low rates of discontinuation due to AE. Here you can see the table. And for individuals who will switch to INSTI-based regimens when they have already achieved viral suppression with previous regimens, switch to INSTI-based ART are safe and there were low rates of drug-related SAE, and again, low rates of discontinuation due to AE. Pretreatment resistance of HIV-1 to integrase inhibitor is rare. So in many high-income countries, there is no recommendation for genotyping testing before starting integrase inhibitor-based regimens. And also performance of genotyping was considered not cost-effective in this situation. So in this map, you can see the prevalence of resistance of HIV-1 to integrase inhibitor has been quite low, although the studies in these Asia-Pacific regions remain limited, and with a case number from dozens to more than 1,000. But the message is that the prevalence from the current available studies suggests that the resistance of HIV-1 to integrase inhibitor is low in this Asia-Pacific region. But still, we have to continue the surveillance study if integrase inhibitors containing regimens are going to be widespread use in this Asia-Pacific region. And emerging resistance to second-generation integrase inhibitors in the presence of virological failure among the ARV-naive patients, or among those individuals who already achieved viral suppression and switched to integrase inhibitor-based regimens, the rate of emergent resistance is rare, is low. But still, the surveillance data is needed in this Asia-Pacific region. Compared with non-nucleoside reverse transcriptase inhibitors or protease inhibitors, unboosted integrase inhibitors have much less drug-drug interaction. However, caution is still needed, particularly when integrase inhibitors are going to be used concurrently with antacid, carbamazepine, phenytoin, rifamycin. So the audience are encouraged to look up these drug-drug interaction in several well-known websites, such as Liverpool drug-drug interaction website or ESCS website, to understand if the concurrent use medicine would be going to have any significant drug-drug interactions with integrase inhibitors. Use of supplement or antacid among people living with HIV in this Asia-Pacific region may sometimes evade our attention. In this survey, it's a poster presented in this APEC meeting. Our colleagues found that among 513 people living with HIV who had been on stable ART, almost 60% of them use supplements. And many of the supplements contain polyvalent cations that may potentially affect the plasma exposure of integrase inhibitors and therefore lead to treatment non-response. In multivariate analysis, we found the use of antacid and ART adherence less than 90% were associated with any detectable virus load greater than 50 copies in the preceding 6 months. Of all those 4 orally available integrase inhibitors, raltegravir and dolutegravir can be used with rifamycin in treatment of TB. As we all know, the TB, many of the Asia-Pacific countries are still high endemic for tuberculosis, particularly among those individuals who had HIV infection and who present late for HIV care. And for raltegravir to be used with rifampin, the dose of raltegravir has to be a dose at 800 milligrams twice daily. But for dolutegravir, if we dose the dolutegravir just 50 milligrams per day, the C-mean and area under the curve will be significantly reduced by rifampin. So the dose of dolutegravir has to be dosed at 50 milligrams BID twice daily when combined with rifampin. So when combined with rifampin, the twice daily dose of dolutegravir, the area under the curve will be increased by 33% and C-mean increased by 22%. In this inspiring trial, dolutegravir 50 milligram BID dosing, when combined with 2 NRTI, could achieve non-inferiority to efavirenz-based regimen in terms of plasma virus load less than 50 copies when combined with rifampin-containing anti-TB regimen. Since TB is an endemic and very important disease here in this Asia-Pacific region, treatment of latent TB infection, LTBI, is an integral component of TB control program, particularly with the introduction of IGRA to detect LTBI. Treatment of LTBI will be increased in the foreseeable future. And this is a very relevant issue and a very important issue in this Asia-Pacific region. Again, similar to the TB treatment, other than efavirenz, raltegravir and dolutegravir can be used to be combined with 12 weekly doses of isoniazid and rifampin, so-called 3HP. And in this trial of 60 people living with HIV who underwent intensive PK investigation, the area under curve of dolutegravir was found to decrease by 30%. And the trough concentration was decreased by 50%. Despite the decreases, the median value of those individuals undergoing PK investigation, the median value of dolutegravir concentration were above 300 nanograms per ml at all time points. And all those 60 individuals achieved viral suppression during and after the monitoring, suggesting that dolutegravir plus 2-NRTI could be used with 12 weekly doses of isoniazid and rifampicin as a treatment for LTBI. And Asia-Pacific region is of high endemicity for hepatitis B infection. For those with HBV infection, the ART regimen need to include either TDF or TAF. Moreover, prior to ART initiation or switch, HBV status needs to be checked before the regimens are to be started. In this single-arm multi-center study conducted in Taiwan, which included 274 HBV HIV co-infected individuals, we found that switch from TDF to TAF can maintain good viral suppression of HIV as well as HBV, and with improvement of proteinuria and bone mineral density. And for individuals who were in a pregnant period, the raltegravir and dolutegravir can be used in combination with 2-NRTI and to achieve a good viral suppression. The birth outcome surveillance study in Botswana revealed continued decline of the prevalence of neurotype defect with DTG exposure at conception since the first report suggesting an increased risk of neurotype defect of the newborn. But the point prevalence decreased with increased number of pregnant women included in this surveillance. But however, the rate remains higher. So it's very important to have informed decision making discussion with the women of childbearing potential to sort of balancing the benefits of the dolutegravir continued regimen and its potential risk for NTD. With the rapid suppression of HIV replication and greater increases of CD4 count with integrase-based regimen, concerns about the increased risk of iris had been raised, particularly in this Asia-Pacific region, where the presentation of HIV infection complicated with TB and cryptococcal meningitis remains common. But in this large clinical trial, intensification of aiding raltegravir to the background standard treatment did not increase the risk of fatal, non-fatal iris, suggesting that iris in this situation, the risk was not increased by aiding or by using integrase inhibitor-based regimen. Weight gain with initiation of integrase inhibitor has attracted significant attention in recent years. In cohort study and clinical trial, as well as clinical trials, for example, in the advanced study and NAMSO studies, exposure to integrase inhibitors, particularly when combined dolutegravir with TAF, was found to be associated with significant weight gain than exposure to a protease inhibitor or NNRTI-based regimens. A similar finding were observed among individuals switched from NNRTI to integrase inhibitors or protease-based regimens switched to integrase inhibitors. But data on the weight changes of people living with HIV who were going to initiate ART or who had been on ART but will be switched to integrase inhibitor in this Asia-Pacific region remains limited. And the impact of weight gain on the potential metabolic complication with more investigation, particularly in this Asia-Pacific region. So in summary, integrase inhibitor-based triple therapy is the mainstay of international guideline recommended initial ART. Second generation integrase inhibitors demonstrate high efficacy and tolerability, and no treatment emergent resistance observed in the clinical trials. Despite the widespread use of integrase inhibitors, the rate of transmitted drug resistance mutation remains uncommon in the limited studies shown in the Asia-Pacific regions. Unboosted integrase inhibitor has less drug-drug interaction than the boosted agent. But additional cautions are needed when we're going to concurrently use integrase inhibitor with NDTV regimens containing rifampin. And our healthcare provider have to be cautioned for any concurrent use of polycatine agents, for example, antacid, among our patients. Patients with HIV, HBV co-infection, the preferred regimen should contain TDF-TF. And the potential risk of NTD does not preclude DTG use under informed decision-making. Weight gain is a multifactorial consequence, and current evidence suggests integrase inhibitors has a greater weight increases compared with NRTI and PI. Thank you.
Thank you, Professor Hung, for your nice update on the clinical use of integrase inhibitor. I'm sure the audience will have many questions to ask. Please send in your questions in advance. Let me move on to our next speaker, or the last speaker of this session here. Dr. Sivaporn Gatechompol. Dr. Sivaporn is a medical graduate from Ramathipati Hospital here in Bangkok, the same as Professor Sasisopin. She also completed her residency training in internal medicine and fellowship training in infectious diseases at the same hospital. Currently, Dr. Sivaporn is working as a senior HIV clinical trials physician at HIPNET, or the HIV Netherlands, Australia, Thailand Research Corporation here in Bangkok. HIPNET is a site of NIH-funded clinical trials unit, working along with the ACTG network. Dr. Sivaporn is currently focusing her work on tuberculosis, both with the ACTG network and with the TB research unit of the Faculty of Medicine, Chulalongkorn University. Dr. Sivaporn will present some of the selected treatment highlights from CROI 2020, with emphasis on regional relevance. Please join me to welcome Dr. Sivaporn.
Hi, good afternoon, everyone. I would like to thank the organizing committee to inviting me to this meeting. Today, my topic is selected treatment highlights from CROI 2020, the regional relevance. I have nothing to disclose, and this is my outlines. I try to focus on the topic that I think is the most relevant to the Asia-Pacific region. The first study is a transitional to TLD in Malawi. As you may know that since 2017, TLD, the fixed dose combination of generic TDF, FTC, and dolutegravir was available in many low-middle income countries. In Africa, many countries have implemented TLD in their first-line regimen, but however, the TLD access is limited in the Asia-Pacific region. However, this study objective is to describe the biological response to TLD. They focus on the transitioner who transformed NNRTI-based regimen to TLD regimen. They have the participant about 1,900, and there's no HIV viral loads testing at the baseline. The plasma viral loads were assessed at 3, 6, and 12 and 18 months, but now they are followed until month 6. So on the right-hand side, you can see the viral suppression rate for the transitional is about 98% of transitional has virological suppression. In terms of virological failures, they do the virological sequencing retrospective from baseline, so they can divide the viral failure from suppressed as baseline and non-suppressed as baseline. You can see at the right-hand side, they have only 1.2% of the transitional who suppressed as baseline have a virological failure. For the non-suppressed as baseline, more than 86% of them have viral suppressed. For the confirmed viral failure, they have 5 transitional who have confirmed viral failure, and 2 of them developed DTG resistance at month 6 in combination with previous resistance with TDF. In terms of safety, 2 cases of this have severe psychosis leading to TLD discontinuation and the symptom of relief when they switch the ART back to NNRTI regimen. So it's a cohort of well-suppressed NNRTI regimen and transition to the DTG that can maintain the viral at month 6. However, for the 2 cases that have severe psychosis and viral load failures, there is a need to have follow up this patient. So the next study is a Gemini study. The Gemini is a randomized control trial that compare between DTG TTC and DTG TDF FTC in HIV naive patients, about 2,000 participants. As this study is report the virological confirmed virologic withdrawal at week 96. There is 11 participants in DTG TTC arm versus 7 in DTG TDF FTC arm. So the good news is there is no emergent genotypic and phenotypic resistance to Integrase or NRTI was observed in the study. As you can see in the summary table of confirmed virologic withdrawal in DTG and GTC arm, most of them are non-adherent or have a treatment interruption. So this study is confirmed the durability and safety of use of 2 drugs, DTG and 3TC. So another dual therapy, this is the Atlas 2M, the injection of cabotegravir and rilpivirine compared between every 4 weeks and every 8 weeks. This is a phase 3 randomized and multi-center non-inferiority open label study. The participants were included from Atlas study who have a virological suppressed, or they can also recruit from the standard triple therapy. So they was randomized into 1-to-1 to receive oral cabotegravir and rilpivirine, except participants from Atlas that already on the injection, and they were randomized into group, about 500 in each group, to Q8 week and Q4 weeks. So the study endpoint of this study is HIV RNA more than 50 copies as week 48 by FDA snapshot, intention to treat, and non-inferior margin at 4%. So you can see the outcome of the week 48 of this study. The 94.3% of the participants in Q8 week have a virological suppressed, and 93.5% of Q4 week have virological suppressed. The treatment difference between 2 arms is of 0.8, which is made the non-inferiority of a trial, and they meet the endpoint, both primary and secondary endpoint. In terms of vertical failure, you can see the very low vertical failure in each arm is only 1.5% in Q8 week and 0.4% in Q4 weeks. And for the Q8 week, they have 6 in 8 participants develop ribavirin resistant mutation, and 5 in 8 participants develop integrase inhibitor in Q of 8 weeks. For the safety, the injection well tolerated. 98% of injection site reaction was grade 1 or 2, and median duration was 3 days. And the patient prefer injection over oral therapy, and patient previously received corticosteroid injection prefer Q8 week dosing over the Q4 weeks dosing. I think this study is quite interesting, especially during the COVID-19 situation that many people have challenging to refill their ARV. So the next study is ART-PRO trial. This study is trying to answer that can we use the DTG-TTC in patients with have a history of TTC resistance. I think many of the clinicians has this question in their practice. So this is a single open label pilot study, include HIV and HIV-1 infected adults who have a CD4 more than 500, more than 350, and have a viral load less than 50 copies per mil more than 12 months, stable on ART, ever used FTC or 2GC, and never used the integrase before. So they have 2 groups, 20 participants in each group, and the proportion of participants at 96, the primary endpoint of proportion of the participants who have viral load suppressed at week 96. So the left-hand side is a summary of the participants in this study. The key is for the no historical M184 mutation. You can see that they can detect the M184 mutation by next generation sequencing. Even they did not detect that in the Sanger genotype. So the right hand side is the result of the study. So you can see in the historical M184 group, they have about 86% viral suppression compared to 95% of in the group of no historical mutation, and no vertical failure in both groups. But however, if you see at the no virologic data at week 96, 14% of the historical M184 group don't have the virological data, which is make us have to interpret this with caution, because I think the sample size is too small to answer the question that's what can we use this or not in real life. So I think we need more study that have more sample size to make sure that have power to answer. So move to the metabolic disease. So this study is a predict 10-year risk of diabetes and cardiovascular disease from the ADVANCE trial. The ADVANCE trial is a phase 3 randomized open label study in South Africa. They enrolled the participants, about 1,000 participants into 3 arms, include TAF, DTG, TDF, DTG, and TDF FTC equivalents. They previously report the treatment emergent obesity at week 96 is high in women than men. So for this time, they summary the change of the cardiovascular disease and diabetes. So they report the emerging metabolic syndrome was higher in TAF DTG arm compared to the TDF FTC equivalence arm. But there are no difference in terms of Framingham series in every arm. And and they have a higher chance of Curie's equation between TAF, DTG, and TDF, between TAF, DTG, and TDF, FTC effluents. Also with the risk of diabetes was higher in TAF and DTG arm. So, and this study is an impact study. This is a study in pregnant women who living with HIV. They enrolled pregnant women who have gestational age at 14 to 28 weeks. The participant can have pre-NT-ART up to 14 weeks before entry. And they randomized to 3 regimens. This is the same regimen at one study. So the primary efficacy analysis of this study is compare the combined DTG containing arms to effluent arm. The primary endpoint, we look at the delivery HIV RNA less than 200 copy. So the conclusion is DTG containing regimen has superior virologic efficacy at delivery compared to effluent TDF FTC. And the DTG TAF have the lowest composite frequency of adverse pregnancy outcomes, and same as at one study, there are more weight gain in DTG and TAF arm. So let's move to the tuberculosis. This is an interesting study from Africa. This is a WIP3 TB study. This study have 2 primary objectives. Part 1 is a treatment completion rate and effectiveness of 3 months of isoniazid rifampicin versus 6 months of INH in people living with HIV. And then part B, they compare the effectiveness of 3-HP given annually, or we call P3-HP versus 2-HP once. They include people living with HIV age more than 2 years. We have no evidence of active TB, and on ART more than 3 months. About 4,000 participants were enrolled to this study, and they randomized into 3 arms. So this is a primary outcome of the part of the study. Part A, treatment completion. In 6H arm, they have 50% of participants have treatment completion compared to GHP arm, which has 90% of participants have complete the completion. For the part B, the TB incidence overall 24 months compared between 3HP and P3HP arm. There is no difference in terms of TB incidence between this arm. So the conclusion is the TB preventive therapy, the GHP is higher completion rate compared to 6H. And in the high burden setting country, the 3HP annually is not add more benefit to once 3PHP arm. So I would like to stop my presentation here and happy to answer any question.
Thank you, Dr. Sivaporn, for bringing us update of the CROI 2020 meeting. Now we have all 3 speakers on the same platform now. I would like to thank all 3 of you that you keep up to the time so that we have about 20 minutes of questioning and then discussion here. Since Dr. Sivaporn is the last speaker, before I will ask the question that being posed by our audience here, I would like to ask Dr. Sivaporn first that
yes.
your task in terms of reviewing the virtual CROI this year and picking up some important issues relevant for Asia-Pacific region here. Many people would like to do the same thing as you are doing. We just wonder how you do it. I.e., for example, do you have to read through all the abstracts? Do you have to listen to or view all those recorded sessions? or how do you have to talk to the speaker to ask their advice or they ask the slides, and how do you select whatever topic that you think that that will be worth for presenting? Please tell us and teach us how to do that.
Thanks, Dr. Praphan, for asking me this question. First, I joined the CROI 2020 virtual meeting, and I read through all the abstract book that to look at whether section with relevance to Asia-Pacific regions. And I can, as you know, many of you may know, we have a lot of stuff in the internet, in the clinical care option, something like that. So if you need more information, you can look at each study via the program and also with the record, the section from CROI website as well.
It's a very challenging and labor taking job. Yeah. Okay, let's move on. I have a question from Professor Kiat and two others. The thing is, in our region here, when we should do a baseline resistance testing before starting patients on ART, shall we wait until the resistance is over 10% or 15% of the general population? Or some people will say right now the trend of resistance is not increasing because now the drug is much durable and easier to take, and as well as we have integrase inhibitors. So there is no need now to do any baseline resistance testing. I just wonder whether or not this is true. I don't see Dr. Sasisopin on this panel yet, or if the Sasisopin is still on the panel, please answer this question first, and then we'll come to Chien-Ching.
Yes, good afternoon, Praphan.
Oh, yeah.
So I'd like to respond to your question, and thank you for your questions. So I think it depends. Right now, overall data of pre-treatment drug resistance is still less than 10%. So, and another thing is the cost of testing is still expensive. So in Thailand, it's about 160,000 US dollars. So it's about 5,000 baht. So it's very expensive now. Even some tests is less, like in-house, like in HipNet. So you have like less expensive tests. So according to the WHO guideline, they said that if any country has more than 10% pre-treatment resistant testing, is maybe cost effectiveness to do the test. But in your country, if you have integrase-based first line regimen like dolutegravir, it is quite potent. So it may not need to do resistant testing in your country. So it depends on the what is your first line treatment guideline in your country, and what is the prevalence of pre-treatment HIV drug resistance in your country, and how much of the testing.
Okay, before I move to Dr. Hung, the question coming from our audience here, is there any way that we can reduce the cost of resistant testing in our region? Whatever means, about purchasing or whatever. Do you have an idea on that one?
Yeah, several years ago, I tried to do the research about we call short RT. So we select some mutations. We not run all through resistant, reverse transcriptase or a gene. So it's cost about 50 US dollars, but it's still high, but it's cheaper than regular testing.
Okay. May I ask Chien-Ching now? Especially if we want to start with dual therapy, dolutegravir and 3TC, or dolutegravir plus mupivirine. In such case, do we need to do any baseline NRTI or NNRTI resistant testing before using that two combinations?
Yeah. Thank you for this interesting question. I think there are two questions. The first one is, if we want to start dolutegravir plus 3TC, if we need pre-treatment resistant testing before we initiate dolutegravir plus 3TC. From my previous review of the published data in these Asia-Pacific regions, I found that the prevalence of resistance mutation to second generation, particularly second generation integrase inhibitors, has been rare. So, and also the pre-treatment resistant testing is pre-treatment resistance mutation, the prevalence to lamivudine in our previous experience was about less than 2%. And here in Taiwan, the pre-treatment resistance, the prevalence was above 10%, which means that we here in Taiwan, if you're going to start an NRTI-based regimen, we need pre-treatment resistant testing. But for the prevalence of resistance to integrase inhibitor and lamivudine itself has been low. So probably in this Asia-Pacific region, for individuals who were ARV naive, we probably don't need the pre-treatment resistant testing if we're going to prescribe or initiate dolutegravir plus 3TC. But for dolutegravir plus ripivirine, probably it's really not the same logic. For in regions where the resistance prevalence remain high to NRTI, it may cause a little bit caution if you're going to prescribe dolutegravir plus ripivirine as an initial therapy for ARV naive individuals, or for using dolutegravir plus ripivirine as a switch regimen for those individuals who have been on suppressed antiviral therapy.
So, for example,
that's
people who
my short answers. Thank you.
Yeah. So for someone with previous resistance to 3TC, and then they're being suppressed by 3 drugs, then if we want to switch to 2 drugs, using integrase inhibitor, dolutegravir plus 3TC, can we use that with confidence because of this increased fitness of 3TC resistant mutation?
Yeah, it's a very interesting question actually, but the data remains quite limited. Their ART Pro just shown in our previous speaker, and also their data from Italian investigators suggesting there are few cases of HIV-1 with harboring MYD4V in individuals who have been on stable or suppressive antiviral therapy. And these individuals were switched to dolutegravir plus 3TC, and they appear to be able to maintain viral suppression. But the data remains quite limited. I think we need caution in concluding that the M184B has or has not any impact on the maintaining viral suppression. You're going to use dolutegravir plus 3TC as a maintenance antiviral therapy.
Okay. Yeah, I agree with Dr. Hung, because the ART Pro trial that I just presented that showed the history of M184 participants can already suppress and switch to DTG and 3TC have shown no viral failure as 2 years. But however, it's very few participants, only 20 participants per arm. So I think we need more prospective try to evaluate this regimen in patient who has a history of N184 mutation.
Okay.
And how about if, I mean, in Thailand or in Asia, we don't have pre-treatment resistant data. So then someone like receive 3 drugs for 2 or 3 weeks, and then how would you confident to switch to 2 drugs? At that time, we don't have any resistant at baseline. So can you recommend to switch? So anyone from 3 drug to 2 drugs, because we don't have any pre-treatment resistant at baseline.
Yeah, for me, I think it probably depends on the frequency of monitoring of virus load. If we are able to monitor virus load in a very short period of time and very frequently during the, for example, in the initial 6 months of switch, within the six months of switch, probably we can minimize the risk of emergent resistance to dolutegravir. Yeah, I agree with you all that we need a prospective study, and we need frequent testing and monitoring to ensure that we will not endanger the efficacy of dolutegravir.
Okay, thank you. There's a question from Myanmar asking that in Myanmar they only have dolutegravir as the only integrase inhibitor available. If the patient is resistant to dolutegravir containing regimen, what would be the alternative or the second line treatment for that? Change it to protease inhibitor, or can we switch to other integrase inhibitor? Professor Hung?
Yeah, I assume that this individual who was found to have HIV-1 harboring resistance to dolutegravir, he or she would probably was switched from NNRTI to the dolutegravir based regimen. So under such circumstances, I would suggest that the protease inhibitor based regimen, protease inhibitor based plus to carefully selected NRTIs will be the best regimen for this individual with who had failure to dolutegravir based regimen and had a emergent resistance to dolutegravir.
Okay. When you talk about the first line regimens in the 6 Asian countries, I assume that all of them are using brand name ARV. Not any country, even China, is using generic drug. But in Thailand, in many regions, we are very interested in TLD. I would like to ask Chien-Ching about what's your feeling, especially in Taiwan, about TLD as compared to big TAF or dolutegravir TAF FTC, for example.
Well, maybe I'm not in a good position to answer this question because I have no experience with TLD. But I think according to those experiences shared by many clinicians, I think TLD could be a good option for HIV infection, either as an initial therapy, first-line therapy, or as a suppressive therapy, switch therapy for maintaining viral suppression. But yeah, you're right. In the 6 countries I've shown before, they're all using brand name integrase inhibitor-based regimen, particularly single tablet regimens.
Sasisopin, you have anything to add? Because she is very active in terms of getting TLD registered here in Thailand.
Yeah, if you compare TLD, it is a tenofovir, and the brand name like big TAF is TAF. So I think the only big difference is TAF and TDF. So we need to choose between TAF and TDF. So of course, if the patient have a chronic renal failure or end-stage renal disease, also have a bone disease, so TAF may be better than TDF. And another thing, we're waiting for the data of rifampicin and TAF. So in Asia and in Thailand, we have a lot of tuberculosis, and we have to use rifampicin. So we need data of TAF and rifampicin. It should be used, but we need like confirmed data. So if we can use rifampicin, so it can be used with either TAF or TDF. I think the only one thing is renal problem and bone problem between TAF and TDF.
Yeah, but I have to add one.
Pregnancy as well.
Yeah.
And pregnancy.
Okay. But I add to add one topic for TLD and TAF with TTG. As in advanced study, you can see the metabolic change is more pronounced in TAF, TDF, TAF and
DTG.
Yeah, compared to TDF, DTG, even compared to efavirenz. So the TAF DTGs maybe have a
weight gain,
and increase the metabolic syndrome in advanced studies. So I think Asia, in my experience, using TAF, DTG, we saw a lot of participants have weight gain and compared to TLD as well. So it may be something that we have to think about that, because we have more participants that elderly and have cardiovascular risk.
Okay. Since this session here is mainly on integrase inhibitor, I just would like to ask Chien-Ching in terms of first generation integrase inhibitor and the second generation or whatever generation. Once the second generation is in the market, what do you see the future of the first generation integrase inhibitor, i.e. raltegravir? For example, when you have bictegravir, Gilead will stop elvitegravir, for example. I just would like to ask your opinion about what's the position of raltegravir when all the others are out, because it seems to me that it has least drug-to-drug interaction. Please, Dr.
Yeah, indeed. I think raltegravir is really a good drug. Raltegravir could be given to pregnant women. Raltegravir could be combined with rifampicin in the treatment, although the dose has to be increased. But raltegravir could be combined with rifamycin. So in this Asia-Pacific region, I think raltegravir still has its role in terms of the HIV treatment. But the weakness with raltegravir is, as we all know, that they had a low genetic barrier to emergent resistance. But lower genetic barrier is not really a major issue if you're going to achieve viral suppression. I think to achieve viral suppression depends really on the tolerability of the drug and the adherence of the individuals to the raltegravir prescribed. Not really the emergent resistance. The emergent resistance only cause concern when biological failure occurs. So I mean, raltegravir still has its role. I mean, if the price of raltegravir could be even lower, and for the other first generation integrase inhibitor, the abacavir. The abacavir is only co-formulated with cobicistate, emtricitabine, and TAF. And the strength is it's a single tablet regimen. And on most occasions, the tolerability is very well, and the safety is also quite ensured. And so the rate of discontinuation of abacavir, cobicistate, and emtricitabine and TAF has been low. But the weakness, I think, with the ECF tab is really regarding the co-formulate cobicistate, because cobicistate will cause much similar to ritonavir, will cause drug-drug interaction with many concurrent medications. According to my previous experience with ECF tab, it's really a good agent.
And as a switch regimen, the weight gain with ECF TAC within 48 weeks was about less than 2 kilograms over the 1 year follow-up among the Taiwanese HIV positive individuals. So and it's quite I mean it's easy to take, just a single tablet regimen. But we still have to be cautious about the drug-drug interaction between the copacetic with the other agents, the other medications we're going to prescribe, either in the hospital or any medication purchased over the counter outside the hospital.
Okay, thank you very much. We are just running out our time for discussion. I would like to thank all the three speakers and hope to see you again. Before I will close these sessions, I would like, after we finish this, we have 20 minutes of coffee break, and then we'll have the second session of today, which is on critical aspects of implementation of PrEP. We have speakers from France, Malaysia, Taiwan, and we have Dr. Nitya Phanuphak, who's my daughter, as a co-chair, this chair of these sessions. So I hope you come back and join the second sessions. But we remember that besides the sessions after the end of the second session today, we have meet the speaker opportunity. So if you want to talk to any of the speakers listed here, okay, you please sign in, sign up that you will which speaker that you want to talk to, and it's the same for today and for tomorrow. This is the so-called speaker that will talk to all of you here. So enjoy your coffee and come back later on. Bye bye.